Yes, I can record now.
Okay,
Okay.
good.
Thank you, sir.
Let's wait for 5 minutes. Right, we just wait for these people to join. Saranga, just remind me, when do you start clinicals? August, is it?
Yes, sir. August, sir.
August cover, when?
The exact date, sir. Just a second.
They haven't
sir.
given you a timetable or anything.
So they have given us a tentative timetable, sir.
In that, what
So
have they
it
said?
will be August 24th, sir.
August 24. Okay, that's quite a long while off then. So
Yes, sir.
when do you officially finish your electives?
Electives will be, this is our third week, sir.
Right.
Next week will be our last week.
Okay.
So, and then there will be another week for pre-examination study leave, and then our reproductive exam on the 17th, sir, and then 24th they'll be starting our
Right. So 17th is your exam.
Yes, sir.
Hari, okay. So let's start off. First of all, I hope you guys are doing well. This is rather difficult talking to a screen, but that's fine. So the main objective of these sessions are, I know that you'll be starting your medicine appointments in August. So it's just to introduce you to the basic principles of case presentation, interpreting symptoms and signs. Okay, so that's basically going to be what we are going to do. Now, because so I just summarize the whole course in medicine just as an introduction. So you already had your first appointments in medicine. Okay, And the objective of these appointments ideally were for you just to learn the structure of how to take a history and the basic technique of examination. Okay, and we did some introductory sessions to you before you started the first appointments. So basic history taking and examination, just the techniques. Now, the objective of the second appointment in medicine is slightly a little bit more advanced than that. Now, because you have completed almost all your modules, you have a good idea of diseases, their symptoms, signs, and management. So second appointment now is for you to obviously brush up your skills of history taking and examination, and also to go in depth into the symptoms and signs, and to make a diagnosis and to plan out a reasonable plan of management. So that's your objective for the second appointment, okay, in medicine. And obviously, when you come to your professorial appointments, there it will be mostly brushing up things, working as a house officer. What are the skills that you need to know when you work as a house officer, and just preparing for the exam. So you have to have these three segments clearly defined. Okay. So I usually do these lectures in the professorial appointment, but I've understood that doing it earlier would be much more useful to you, with obviously a revision when you start the professorial appointments. So basically these classes, there are a few classes that I do. This is basically what I used to do in the first week of professorial appointments. But now I realize it's much more useful for you guys to learn this a little bit before that, so that you can okay, so that you can practice for your and practice during your appointments. Okay, Hari. Good. Now, as we go on, if you have any questions, put it on the chat. I'll stop in the middle and answer when we have some questions. Okay, Hari. So let's start. Now, today we are going to, so basically we have 5 sessions planned, 5 days, 6 sessions planned. Today we'll talk about the history, okay, and how to do an effective case presentation. And we will have 5 days for the systems. So tomorrow cardiovascular, we will do the systems. And the systems, I will quickly revise the examination technique, but focus more on how to interpret physical signs. For example, what does bronchial breathing mean? How do you interpret bronchial breathing? How do you analyze an upper motor neuron type lesion in the nervous system? So we will focus a little bit more in depth on physical signs. Okay. So that will be 5 sessions, 2 sessions for neurology, because I know that you find it a bit difficult, and the module of course is excellently done, but sometimes, at least most of the time, people have difficulty in translating this into clinicals, and there is obviously a phobia of neurology which is universal. Okay, so we'll take 2 sessions for neurology. One will do the cranial nerves, other one the limbs. Okay, so that's the structure for these few days. When we finish this, then obviously you'll have your exams, and I definitely don't want to do any classes during exams, because none of this is going to go into your head during that time period. But then after your exams finish and corresponding with your start of clinicals, once a week we can have one of these sessions where we take a case and discuss on that case. These cases can be from the wards, from the patients that you see, or we can do some cases that I have prepared previously. So that's basically what this plan is going to be. So for the next 6 or so days, starting from today, we will learn the basic principles of history taking, and then how to analyze signs and the technique of examination. Hi, Patanga. Fine. Okay. Right now, this slide is extremely important. You have a very bad habit of just not paying any attention to things that don't come for the exam. Then always reproduction. You think of reproduction, but now your exam is reproduction, so you're thinking a little bit more about that. But remember, these sessions are extremely important, and if you listen to these carefully, you will definitely do very well at the final exam, which is not very far off. Finally, right? Okay. So basically, in medicine, you have 2 types of cases. Okay. or in the exam, you will see these as long cases. Because that can be dealt with in the professorial appointments, how to prepare for the exam and so on. But at the moment, I'm going to keep this broad. In medicine in general, the type of cases that you will see going into your second medical appointment, there are two types of cases broadly, okay? Broadly, there are two types of cases in medicine. One type of cases, the emphasis of the case will be on diagnosing, okay? And these are called diagnostic cases, okay? The patient will come with a certain set of symptoms, okay? The patient will come with a certain set of symptoms, and your idea in that case is to establish a diagnosis, right? So those are called diagnostic cases. The second type of case is, you have cases where there is no diagnosis to be made. The diagnosis is already there. A classical example would be something like diabetes mellitus. The diagnosis is already there. You don't have to make the diagnosis. But the patient comes with a different problem. And this is more of a management problem, okay? So, for example, patient comes with poorly controlled diabetes or some complication of diabetes. So here your focus now in this particular case is to try to optimize the management of the patient, not to make a diagnosis. So these are the two types of cases that you will encounter when you go to the wards in your second appointment. I'm looking this in a different angle now. පළවෙනි appointment එකේ මේ part 2 කොතනද part 2 එකක් කුස්සිය කොතනද ඒ වගේ බලන්න නෙවෙයි. Now you are really going to learn some medicine in the second appointment. Okay? Hari. So there are diagnostic cases and there are management-based cases. And the way you approach these cases is slightly different. That's why I generally classify them into these two parts. Now, whatever the case, okay, when you are presenting a case, and this you will practice doing in your second appointment, there are certain things that you would do, okay, whatever the case. So when you go to your second appointment, case histories gone. Now, for each case that you see, you have to have these 5 components, right? What are these 5 components? Obviously, the history. Then after the history, you should have a summary of the history. Then the physical examination. After that, you have a summary of the history and the physical examination. That is a more composite or combined summary or the final summary. And then as the 5th item, you have a problem list and differential diagnosis. Okay, problem list and or differential diagnosis. I will explain all of these as we go on. Okay, so up to now, I have told you that in medicine, if you really simplify it, there are 2 types of cases. In one, the case is focusing on a diagnosis. The patient comes with a set of symptoms and signs. You don't know what the hell is going on. You're supposed to make a diagnosis. And then the other type of history is where you have a patient coming with an already diagnosed disorder with some complication or some problem. And there your idea is to optimize the management of the patient. Whatever case you are dealing with, when you present the case or at least write down the case or take the case, it should consist of these 5 components: history, summary of the history, physical examination, a composite summary of both the history and the examination, and a problem list and differential diagnosis. Now, these are some examples. Don't write these down. These slides are freely available. I will give it to you. So these are some examples of diagnostic problems. Okay, diagnostic cases, diagnostic problems. PUO, chest pain, shortness of breath, those sort of things, where the patient doesn't have a diagnosis and you're expected to make that diagnosis. Some diagnoses are straightforward. Some are a little bit more difficult. Okay, so these are examples of diagnostic cases. And when you come to your professorial appointment, you will find that these are the type of cases where you will get for your long case or your exam as well. But you're not focusing on the exam at the moment. Right. And in a series of lectures covering your pre-professorial medicine appointments, I told you that when we finish these 6 days, when you start your appointments, each week we will take a case and discuss this. We can fix a date for this, don't worry. We can fix. But basically, we'll take each of these cases and try to discuss that case. Okay, so that we will do. Okay, in the second half of this series of lectures. Hari. Now we start off with diagnostic cases and how to present or obtain a history and examination of a diagnostic problem. And I have given you examples: jaundice, PUO, chest pain, shortness of breath. These are the problems that a patient, diagnostic problem that a patient comes with. Right. Now, in a diagnostic case, the case should be described in this order. And this you have already been taught. So it start off with the history. Now, all of you know that a history should start with the introduction, name, age, janammanang, ovage katanda. Right? So that you already know. Then, now this is something that is a little bit different from what you have been taught in your first appointment. The first appointment එකට නුඹලා බබාලානේ ඉතින් මේකේ history එකේ කෑලි ගන්නලා ඒක පුරවන්න ගන්න. Now you will realize once I teach this class that your second appointment and professorial case presentation is slightly different from your first year cases. ඔගොල්ලෝ මේ first appointment එකේ ඉගෙන ගත්ත case presentation එකට වැඩිය this is different. Right. So how is it different? So introduction is absolutely the same. The next thing is relevant clinical background. So අපි දැන් කියනවා this 52-year-old man who comes from, who is a teacher or whatever. Now we have to mention the relevant clinical background. Now this is important. Now for example, if a patient comes with chest pain and the patient also has a history of diabetes, hypertension and ischemic heart disease in the past, then you don't have to wait for the whole history to finish and then go to the past medical history to mention this past history. Chest pain and those 3 past histories are very relevant. So you mention that right at the top. So you can say this 56-year-old gentleman with a background history of diabetes, hypertension and ischemic heart disease presents with, and you go to the next point. So the relevant clinical background is important right at the start. You don't wait for the past medical history to come up for you to mention them. Now this is different from Baba Kali history taking. Okay? Baba Kali history taking, you wait for the whole thing to finish, past medical history, okay? Then you say, this patient has hypertension, diabetes, ischemic heart. But this is now different. This is Baba neve then podda Montessorian grade 1 sort of age group. So now you have to say, right, fine. This patient has a significant background of hypertension, diabetes and ischemic heart disease. Then you know about the presenting complaint and subsidiary complaints. That is the why the patient came to hospital. Why the patient came to hospital. Presenting with chest pain. And the fourth component is the history of the presenting complaint. History of the presenting complaint. Which I will talk to you a little bit more in detail in the next slide. So this is the initial part of your case presentation of a diagnostic case. And I have given you the example of a patient with chest pain. So you give the introduction to the patient, give a relevant clinical background. And I gave you the example of hypertension, diabetes, ischemic heart disease. Don't wait for the history to finish to talk about that. You talk about that right at the start. Something, don't talk about those things at the relevant clinical background. Just talk about only the relevant stuff. There. Then you talk about the presenting complaint and the subsidiary complaint and the history of the presenting complaint. Right. Now we move on to the next slide. So we're talking about how to present a diagnostic case. Now, if you were to ask me what is the most important part of a history, I would say without a doubt, it is the history of the presenting complaint. And this is especially important in a diagnostic case. Now, this is where, again, this history taking that I'm teaching you today is different from the ones that we taught you probably in your first appointment, in your introductory medicine appointments. It's a bit different. Now, how do you, so the most important part of the history, especially in a diagnostic long case or diagnostic problem, would be the history of the presenting complaint. Harinda? Right. So how do you write that? How do you present that? The most, and write this down if you're writing it in bold capitals, the most important part of the history of the presenting complaint is to describe the patient's story, right? A chronological story of how the patient presented to hospital, okay? Highlighting all the symptoms the patient had. Now, this requires a lot of skill because our patients talk a lot of nonsense when you ask them what happened, okay? The situation is much more different in England, which I have noticed, where people are much more focused and they tell you what you need to know. But in Sri Lanka, unfortunately, people talk a lot of rubbish and tell you a little bit of important information. So, but it's your skill, and that's why you have to practice this, to take the relevant stuff and put it in a nice chronological sequence, a story in a chronological sequence. You can actually draw a timeline if you like. That is very effective. Timeline, especially in the more complex, long histories, right? You can get a timeline and mark the events on a timeline. Say, for example, the patient comes with shortness of breath. This started about 6 months ago. So you give a chronology of how this started and how this story, the story. And when you present case, when we talk about case presentation, in the second half of our series, we will see practical examples how this can be done. Okay. So give the patient story, chronological sequence, very important. And anitthaka lamai, always when you're using your chronological description, use dates and months, right? Don't say 6 months ago, 3 months ago, 1 month ago. The human brain doesn't work in reverse. Okay, it's very difficult for the human brain to do that. The person who's listening, it's much clearer if you say in March of 2020, the patient developed these symptoms. Then in April, it got worse. In May, the patient was admitted to hospital. 3 points in the chronological order. But that's important. It makes it much clearer to the listener when you say dates and months in your chronology. Don't say 6 months ago, 2 weeks ago, 1 week ago, 3 days ago. Right. So that is a little bit of a important thing when you're talking about the chronology. And when you get the story of the patient, you will see the symptoms emerging, the important symptoms emerging. Probably it will be 1 or sometimes 2 symptoms in your cases, in your undergraduate cases. Always remember to make sure that within the chronology that you described, you have actually described, okay, you have actually described the onset of the symptom, duration of the symptom, progression of the symptom, exacerbating and relieving factors, and associated features. So for each of these symptoms, make sure that in your description, you have included these 5 important points. When it started, how long it lasts for, what the progression is, are there any exacerbating or relieving factors, and are there associated features. So each symptom within your timeline, you have to make sure that it is these 5 points are described somewhere. Now, again, I tell you that experience is very important when you're presenting these cases and these histories. Organizing the information in a nice way to present takes time. And that's why I decided now to teach this to you at this point. Because by the time you come to your final year, there is no time for practice, no time for correcting errors. You should be very good at this. So now you have a nice period of a few months to prepare with all of this and to obviously adjust how you present a case. And in these sessions, the second part of the sessions, I will guide you how to do that. Okay, guide you how to do that. So yes, so history of presenting complaint is probably the most important component of this whole history, especially in a diagnostic case. And it has to start off with a beautiful timeline, especially for the more complex cases, giving the chronological presentation, getting the symptoms, highlighting the symptoms that the patient has. And for each symptom, making sure that you have covered the points that I have just mentioned. Okay. Yeah, so any questions, just put it on the chat. Sachit has said that, yeah, not to tell dates. Some consultants have said not to tell dates, whatever. So dates can be dawasatama kiyanune, but at least you can roughly say, from February the patient started this. So that is something that you need to always say. It's not accurate. Your history won't be accurate. Hari. Now, the next point on the slide is again something which is very different from what you are used to. Then we have gone through some important components in your case. We have given the introduction, we have given the relevant clinical background, we have talked about the presenting complaint and the subsidiary complaints, and we have now also gone through the history of the presenting complaint. Chronological center, each symptom we have given a little bit more description, and we have given a nice picture of what is going on to this patient. Hari. Now, this point is different from what you are used to. Now you stop. You stop taking the history. Right? You stop taking the history at that point. Stop taking history. Now you have to do some thinking. Now, after you have listened to all of this katav, the chronology, you have talked about the symptoms, okay, now you have a picture of what is going on. And this is where your module knowledge has to come in, your knowledge about diseases. And obviously, I will teach you about each symptom as we go on. Now, at the end of your history, chronology, and symptom analysis, you stop taking the history and you write down what could possibly be the diagnosis in this patient. And this is called the differential diagnosis. So we stop the history at this point. On the side of your piece of paper, you write down what are the possible differential diagnoses that the patient could have. Now, for example, I gave you the example of shortness of breath, progressive shortness of breath. Differential diagnosis could be heart failure, could be interstitial lung disease. There are many causes of progressive shortness of breath. And this is what I will guide you to do. You have all the knowledge from your modules, but it's not in one place. So once you do that, you will have a list of differential diagnoses, okay, on the side. And differential diagnosis can be thought of in several ways. Anatomically, for example, shortness of breath, it could be cardiovascular, respiratory, hematological, renal. So that's an example of an anatomical differential diagnosis. Or it could be a pathological differential diagnosis. Could it be a congenital problem, infective problem, ischemic, inflammatory, and the list goes on, neoplastic, endocrine, degenerative. So when we generate a differential diagnosis, we try to generate anatomical differential diagnosis to say what system is at fault. Is it the cardiovascular system? Is it the respiratory system, for example? And then what is the pathological differential diagnosis? Is it a degenerative problem? Do we think it's a neoplastic problem? Do we think it's an infection? Right? So that's how it goes. Okay? So that is on the side. You do a little bit of scribbling. Physics or chemistry, you do that on the side and try to come up with a differential diagnosis. Again, this needs practice. And you should come up with at least 3 to 5 differential diagnoses. Okay, at this point. I would say 5 would be a good, comfortable place to go. Or 3 to 5 differential diagnoses. This one. That make it you need practice and you need guidance, which I will provide, and then you need to practice it. Okay, and example case I will do this for you. Hari. Then මොකද කරන්නේ? Now we have gone right up to the history of the presenting term. We have paused our history taking. And we have written on the side, මේක මොකද්ද වෙන්න පුළුවන්? What is the differential diagnosis possible? Now we go back to the patient and ask specific questions or closed questions. Then for example, progressive shortness of breath could be due to heart failure. From your cardiovascular module, you know that one of the key symptoms of heart failure, shortness of breath, would be orthopnea, that is shortness of breath worse on lying flat, and a symptom called paroxysmal nocturnal dyspnea. That is where the patient wakes up in the middle of the night or early in the morning with chest tightness, shortness of breath, wheezing, and so on. And it's very paroxysmal, right? Unpredictable. So those are two closed questions or specific questions to ask. And that is based on your differential diagnosis. If you are progressive shortness of breath, can be due to interstitial lung disease. Specifically, has the patient had any cough? Were there any exposures to anything, right? Any chemicals or dust or occupational exposures? So these are key points that you ask specifically, and that is based on your differential diagnosis. Okay, and don't worry, we will do this in practice, and I will show you how to do this in a second part, okay, of our series. Now we have looked at the history of presenting complaint in more detail. I told you that the history of presenting complaint is possibly the most important part of a history and a case presentation. Start with the chronology. Make sure that you give a nice story, give a picture of what is going on. Okay. And for each symptom that you describe within this chronology, make sure that you describe the onset, duration, progression, exacerbating and relieving factors, and associated features. Then I told you stop. Think of a differential diagnosis. What could be happening to this patient? Try to do an anatomical differential diagnosis, that is to say what system is involved. Okay. And then a pathological differential diagnosis, see if it's infective, inflammatory, whatever it is. And then based on this list, generally it is very safe to have about 5 at this stage, 5 differential diagnoses or 3 minimum. And then you ask direct, relevant, specific questions for each of these differential diagnoses. Okay? Okay. In sum, asking about the etiology of this differential diagnosis may be relevant. I'll give you an example of that later. So that is what you do. And then you finish off, this is important as well, make sure that you write this down. You finish off the history of the presenting complaint by giving the listener an idea of what investigations and management have happened up to the current point. What investigations and management have happened up to the current point. Now you do this. ඔයගොල්ලෝ සාමාන්‍ය history එකක් ගන්නකොට කොහොම ලෙඩක් කියන්නේ එහෙමනේ. හරි මහත්තයා මට හතිය හැදුනා. හතිය හැදිලා මම ගියා මේ දොස්තර මහත්තයාගෙන් බෙහෙත් ගන්න. ඊට පස්සේ මෙයා ආවා කොළඹ ඉස්පිරිතාලෙට. That's a typical history that you also present in your first years. But here in this new improved, more better way of presenting a history, you have to include this at the end of the history of the presenting complaint. So up to now, the patient has undergone investigation. You can say tertiary care hospital or district hospital. The patient has these investigations done. And in the tertiary care hospital in Colombo, the patient has had these investigations, echocardiogram, CT scan. Why is this important? Because at the end, we'll have to plan out some investigations. I CT scan, if the patient has already had a CT scan. So that is why the point F is important. Right. Finally, end up saying, on the day that you talk to the patient, what are the current state of symptoms? The day that you talk to the patient, what are the current state of symptoms? Today, what is the current state of symptoms? These 1, 2, 3, 4, 5, 6, 7 points are Very, very important. So make sure that you get this into your head very, very clearly. And this is the most important part of your history, especially in a diagnostic problem. So chronology, analyzing the symptoms within that chronology, generating a differential diagnosis, based on the different diagnosis, asking relevant direct questions. In some cases, asking about the etiology of the differential diagnosis might help, not always. Investigations and management up to the current point. This is basically for us to plan out our investigations and the current state of symptoms. That is the symptoms and signs or symptoms the patient has on the day that you took the history or talked to the patient. Fine. I hope that's clear. And then obviously you complete the rest of the history. Okay. Now, review of systems is not necessary now. Because the ඔයගොල්ලන්ට මුලදී අර කාඩ් වල ලියන් එක symptoms we asked you to by heart and ask all of those. Don't do that now, because you have already done that within this structure of the history of the presenting complaint. When you're asking relevant direct questions, you have covered most of the systems review. So the just only thing you have to say at this point is, apart from the symptoms addressed above, the patient did not have any other relevant symptoms. එහෙම කිව්වම ඇති. You don't have to ask cough, few hemoptysis, so ඔක්කොම අහන්න අවශ්‍ය නැහැ. Make sure that you make a clear idea of that. Don't ask all those load of symptoms that we taught you to ask. It's different now, right? Your history is a bit more මොලේ ඇති විදියට ගන්න. හරි, මෝඩ විදියට නෙවෙයි. Right? Then past history, drug history, allergy, and family social history. Those are the things that you complete, right, in the history, or the which you already know. Right. So that's the history. Okay, that's the history. Examination, do a focused examination, starting with the symptom that the system that you think is most likely involved. Then now if a patient comes with lower limb weakness, don't start the examination with the cardiovascular examination. It's stupid. So if you have a neurological complaint, start with the nervous system. If you have a shortness of breath, do the cardiovascular respiratory system examination. And then neurology last. Maybe a quick neurological examination. But detailed cardiovascular respiratory examination. Then also do a focused examination. But cover all systems, but do focused based on your differential diagnosis. All right. So that is how you approach a diagnostic case. Okay, diagnostic case. And again, I cannot emphasize this too much. History of the presenting complaint in a diagnostic case is the most important part of the history. Okay, and this is the structure that you follow. දැන් මේක උඹලට දැන් හෙට ගිහිලා කරන්න පුළුවන් හෙට කොහොමවත් යන්නේ නැහැ මම දන්නවා හෙට ගිහිලා කොහොම මේක කරන්න බෑ so you have to practice this and I will guide you when you start your medicine appointments and then when you come to professorals. I hope that you will be good. Okay, and don't worry, I will continue these Zoom classes for you until you pass out. I won't come back to Sri Lanka for your finals because I'm starting my PhD next month. So but I will do Zoom class, and for your information, we did Zoom classes before coronavirus. So we are very experienced at this process, teaching professorial classes on Zoom that we did before coronavirus, right? Okay. And your 2013 batch, I've done that now for several months. So don't worry about that. So I will be with you for your finals, but I won't be physically there, right? Hurry. Okay. Now, so this is a process that starts from today, okay, and ends with your final exam. Now we go on to the other type of cases, management cases. The management cases, some examples I have given here. And like the list of diagnostic cases, these are the lists that you will see in your final exam also, because these are the most important cases in medicine. This is commonly what you see in a medical ward. Okay. Again, now how do you approach a management case? Again, what is a management case? Where the patient doesn't have a diagnostic issue. Patient has rheumatoid arthritis or something. Well-made diagnosis, no problem. But coming with some complication, maybe a drug complication or a complication of the disease. So the structure is a bit different. Initial part is the same. Okay. introduction, relevant clinical background, presenting complaints, subsidiary complaints, and history of the presenting complaint. Simple. And remember that you cannot forget the history of the presenting complaint. හැබැයි අර වගේ ලොකු හැල්ලක් කියන්න අවශ්‍ය නැහැ because it's a very short, simple presenting complaint. Okay? Diabetes patient, poorly controlled, coming with cellulitis or something. But you have to mention the history of the presenting complaint. Now, don't go overboard with this. Then make a umbala karane මොකක්ද දන්නවද? When this is taught to you, what you do is, for example, you have a patient with diabetes now. For 40 years diabetes and now in CKD. Patient coming with fluid overload symptoms. දැන් උඹලා ඒක ගැන කියන්නේ නැතුව අවුරුදු 40කට කලින් diagnose කරපු CKD එකේ history පටන් ගන්න එපා. Always focus on the history of presenting complaint, which is a cardinal rule in medicine. You have to describe the presenting complaint and the history of the presenting complaint. But it is not as long as this. Okay, you have to do a lot of thinking, right? It's going to be a simple presenting complaint. Okay, so, but make sure that you give a nice timeline and a description of it. Then you go back to addressing the key chronic problem. Okay, and there are certain points that you need to mention about the chronic problem. Then make a for example, if the patient has diabetes, hypertension, ischemic heart disease, CKD, liver disease, and rheumatoid arthritis, then do you need to do it for all of them? No, you have to do it for the disease that is most relevant to the presentation, and the rest can be summarized. Okay, so you don't have to do all these 9 points for 7 comorbidities. The maximum complexity you will get is maybe 2 or 3 chronic conditions in one patient. Okay, but make sure that you describe in detail these 9 points that I am going to describe for the most important chronic condition causing the current presentation. Right, now we take a simple example. Cellulitis in a patient, diabetes patient. So you give the introduction, relevant clinical background, presenting complaint is redness of the legs, swelling and pain, fever, for example, and then you give a description of that, analyze the symptom a little bit. Then, once you have done that, then you go back and talk about the diabetes. So there are 9 points. First point is, when and how the disease was diagnosed first. So make a kohomada diagnose kare. How was this diagnosed? Was it just a routine finding? I'm taking the example of diabetes. Was it a routine finding? Blood sugar වැඩි කියලා දැනගෙන බලපු එකක්ද? So that sort of thing, right? When and how the disease was diagnosed. Then what initial management was given? Okay. In the case of diabetes, what medication was started? Was the patient given lifestyle advice? Initial management. Etiology may be relevant to some chronic diseases. For example, something like chronic kidney disease. Right? Not for all. Then diabetes for etiology, right? So, etiology, if relevant. Then talk about the complications of the disease. So, for example, diabetes, you have to talk about the vascular complications, non-vascular complications. Examples of non-vascular complications are things like infections, recurrent infections. Vascular complications can be macrovascular or microvascular. So you have to describe the complications of the disease. And then give a nice timeline of treatment up to now. Okay? Timeline of treatment up to now. Highlighting any hospital admissions the patient has had for complications. So these are the first few 5 points. How was the disease diagnosed? When was the disease diagnosed? What is the initial management of the disease? Is there etiology that you need to explore? What are the complications of the disease and the treatment up to now? Okay, treatment up to now. In the example of diabetes, metformin, then another drug was added maybe, and then the patient is now on insulin because of poor control. So that sort of description should be given. It doesn't have to be a very detailed description, but you have to cover these points. Then any adverse effects of treatment. For example, in this instance of diabetes, you're talking about hypoglycemia, right? Adverse effects of treatment. And the last 3 points are also important and you frequently forget. So make sure that you make it a point to get this information as well. Follow-up. What about the patient's follow-up? And is the patient compliant to medication? Right? Is the disease under control? That differs from disease to disease. For diabetes purposes, it is the blood sugar HbA1c. For another disease, it might be different. Okay, so the control of the disease. For rheumatoid arthritis, it's more joint pain now, and things like inflammatory markers. So it's different based on the disease, but these are the basic principles. And finally, explore patient education about the disease. What the patient knows about the disease. So මෙන්න මේ points 9 you need to describe in a management problem. So management problem is patient has a chronic diagnosed disease, comes with a complication or comes with some problem related to that. Okay. So describe as we have done, Tamai, the initial part. Make sure that you don't forget the history of presenting complaint. Make sure that you describe that, but you can describe that relatively short, not as detailed as you would do in a diagnostic case. Okay. And then move on to these 9 points about the chronic disease. When was the diagnosis made? Initial management, etiology, complications of the disease, treatment up to now, complications of the treatment, follow-up and compliance to medication, control of the disease, and patient education about the disease. Okay. So that is basically how you describe a chronic problem. And again, I emphasize, if the patient has 7 chronic problems, you don't need to do this for everything. Highlight, describe in detail the disease that the patient is cause for the patient to come to hospital, and the other ones you can be a bit more obviously very summarized presentation. And then obviously, like in the previous cases, you complete the rest of the history. Review of systems probably not needed. Past history, drug history, allergies, family history, and social history. Now a little bit more about the social history in a patient with a chronic disease. Okay, a little bit more of information needs to be given or at least extracted when you have a social history in a chronic disease. Personal and family details are important in any case. Habits like alcohol, drug use, smoking are important in any case. But the next few points, 3 to 8, are very, very relevant for a chronic disease. Okay, and you should get that information. I will give you an example sometime. Now, I told you I won't focus a lot on the exam, but I can remember we gave a patient with chronic kidney disease to one of the candidates in the final exam. The only thing the examiners asked for, give me the social history of this patient. And therefore, you need to make sure that chronic diseases, where you get a good history about their social circumstances. So what is this? Disease impact on the patient. Activities of daily living. These are the essential activities that the patient should be able to do. IADL can instrumental activities of daily living, and that is additional things like cooking, for example. Okay. Right. And cleaning the house, sweeping the house, that sort of thing. So you need to explore how the disease impacts the patient's ADL and IADL. This is especially, and make sure that you may make a note of this, especially important in neurological and rheumatological diseases. Okay, neurological and rheumatological diseases. So it is very, very important. So disease impact on the patient needs to be explored and described. Then what sort of impact does this have on the family and the caregivers of the patient? Now you see this most often. Young, say in a family, the husband gets some chronic disease, nobody to care for the children, nobody to care for the wife. the financial situation is very poor, so on. There's a lot of impact on the family and other caregivers. A person with dementia, there's a major impact on the caregivers, right? So explore that and describe that. Then move on to the support available to the patient. What sort of help is available? Is there family support? Is there extended family support? Is there help from the government or non-governmental organizations? So that sort of information should also be taken. And again, these are more relevant in cases like neurology, chronic kidney disease, right? Give a good description of the environment, the household environment, and the community environment. Again, important, especially in neurological and rheumatological diseases. Okay, very, very important, right? And then about education, we already addressed that. And what sort of psychological state the patient is in at the moment. And you will find surprisingly that patients with most of this chronic disease might have suicidal ideas. And if you miss that sort of thing in the exam, you will fail, because that is a critical problem for this patient. They have active suicidal ideas. Patient with chronic kidney disease have active suicidal ideas. So make sure that you address the psychological state and concerns in the social history. Hari. So this is what we need to talk about in the social history level. Hari, and remember that this is very, very important in a management-based long case where the patient has a chronic disease. Okay, talk about the usual things like personal details, family details, habits, but then focus on the disease impact on the patient, the impact on the family and caregivers, support available, the environment, neurological, like essential that you talk about the environment, right? The household, whether there are steps in the house, where the toilet is, that sort of thing is very, very important. Okay, and then about the education of the patient regarding the disease, and also the psychological state of the patient. Especially look out for, you don't have to do a psychiatric history here, but look out for symptoms of depression, okay, and suicidal ideas. Right. Okay, fine. So that is a basic overview of how to present or present a management-based long case. So to revise what I have just said, a management-based long case is where the patient has a chronic problem, diagnosed chronic problem, but comes with a complication of that or something related to that. Okay, and then this is the outline of how you take that history or present that history. Okay, and within the chronic disease, there are 9 important points you need to cover. Okay, මේවා card කෑලි වලම ලියන් ගියට කමක් නැහැ, because it will guide you to get a proper case history. Okay, fine. Right, so coming to the last part of the session today. Now I showed you a slide right at the start. Obviously, first I told you that cases in medicine can be diagnostic or management. Diagnostic yani patient comes with a set of symptoms and signs, and you're supposed to make a diagnosis. Management cases are where the patient has a chronic diagnosed problem and comes with a complication of one of these problems. And then their element is to focus a little bit more on the chronic disease and then focus on how to optimize the management. And for that, you need all of this information, 9 points there, and also a little in-depth social history as well. Okay, fine. Now we come to the last part. As I told you in a slide at the start, I told you that when you take a case history or case, you have to have several components in this. And you saw the word summary and problem list coming up. Okay, so I'll talk a little bit about these two things and then we'll stop for the day. So remember that a summary is not a short form of the history and the examination. Okay, it is the essence of the history and the examination. Now this is very, very pertinent because you see this in books and literature. Now most of you like to read, right? And you read translations of books, okay? English books or in your language. Now there are 2 ways of doing a translation, as you might know if you know your literature. You can do a word by word translation of the original text. Word by word translation of the original text, which is boring. Or you can take the original text and interpret it and give the essence of it in your translation. A summary is that. A summary is looking at the whole history and the examination, giving an essence or an interpretation of the history and the examination. Okay, it is not just cutting words here and there and word to word translation. Okay, it is just the essence of the history and the examination. Writing a summary is the most difficult thing to do. It is very, very difficult. Okay, and you will not learn this until probably you become a consultant, how to do this properly. Okay, because it requires a lot of experience. But we will slowly learn. So in the next few months, we will learn how to do this. And obviously, when you come to your professorials, you will learn more about it. Okay. Hi. And a summary is very, very important. And you should give the essence of the history and the examination. Okay. Fine. What is a problem list? A problem list basically can include several components. A problem can be a symptom. Okay. A problem can be a diagnosis, or a problem can be a management issue. Okay. So for example, shortness of breath for 3 months is a problem. Okay. It's a symptom based problem. Okay. Example of a diagnosis, a problem as a diagnosis, diabetes mellitus for 9 years is a problem, right? It is a diagnosis based problem, right? Poor control of diabetes mellitus is a management problem. Okay. So those are various examples of problems. When you write a problem list, you have to classify it into two. And we will learn how to do this practically. Don't worry. This might not make sense now, but it will make sense when we do when we finish and when you finish your medicine appointments. So basically, problem lists can be classified into active problems and non-active problems. Active problems can be, say for example, worsening shortness of breath for 3 months. That's an active problem. Male data diabetes, but that's not an active problem. That's a non-active problem. Okay. So you have active medical problems, non-active medical problems. And there are non-medical problems as well. Okay. There are non-medical. There could be active non-medical problems like say financial problems, right? Non-medical. And there could be non-active non-medical problems as well. Okay. So these are some examples of problems. But basic classification, active, which is pressing, that is the current problem that the patient comes to hospital with. And there may be a whole lot of other background medical, non-medical problems. Okay. I won't talk about potential problems now. I will leave that to our case discussions in the second half of this series. Okay. We'll talk about that later. All right. Okay. So that is that. So before I answer your questions, I will just summarize the session today. Okay. So today is the beginning of a series of 6 sessions where we learn or relearn history taking, examinations, and interpreting physical science. Okay. And today I have given you a different way of how to approach a case presentation in medicine. Okay. And a slightly different structured history. Okay. So I've told you that there are 2 types of cases in medicine: diagnostic cases and management cases, right? Then number 2, I have shown you the structure of a case presentation for a diagnostic problem and a case presentation for management problem. Within the diagnostic problem, the most important component is the history of the presenting complaint. And there you need to describe the chronology of events. You need to describe the symptoms, analyze the symptoms within that chronology. Okay. Then you have to think of a differential diagnosis, ask specific questions, explore the etiology, and then also describe investigations, management that has happened up to the present point, and the current symptoms of the patient. And that is by far the most important part of a diagnostic problem. Then we went on to talk about management problems. Management problems are problems where the patient has a chronic problem and comes with a complication or some problem related to that problem, right? And then again, you describe the presenting complaint and the history of the presenting complaint and focus a little bit more on the chronic problem using the 9 points that I mentioned, and also make sure that you explore the social history in depth, because that is very important in these chronic management issues. And the highlight of this management case would be ultimately for you to design or optimize the management of the patient. Then finally, I told the summary is the essence or the interpretation of the history and the examination. It is not a cut, shortened form of the word-to-word history and examination. Okay, it is the essence. It is the interpretation. Problem list can be a symptom. A problem can be a symptom. A problem can be a diagnosis. A problem can be a management issue. Problems are classified into active problems, which are causing concern at the moment, or non-active problems where there is a problem or list of problems in the background, but they are not important. They are quiet at the moment. Okay, so that is how you talk about a problem list. Both of the summary and the problem list components, we will obviously learn to do that in practice when we do our case presentations later on. Okay, Hari. So that is what we did today. So let me answer your questions now. And please post any more questions on the group as well. Hari. Fine. So in a management type of issue, can we tell that the patient is a diagnosed patient with a particular condition at the beginning? Right. So you can do that if you are confident that the diagnosis, and also I think this is related to another question that Purna has asked, where you can you believe what the patient tells you? Ledak, arthritis, can you believe that? And can you present it at the start that the patient is a diagnosed patient with something? Yes, you can, but make sure that you dig around a little bit and make sure that the patient is talking about what you think he is. Then ledu arthritis, osteoarthritis, rheumatoid arthritis, nikamma age pathekak mada arthritis. So you're a doctor now, you're at least a little bit more senior medical student now, so you should be able to confirm or corroborate that information, accuracy check. So if you have done that, yes, you can. And the examiner will most likely ask you the person who is listening to you will ask you, are you sure that this patient has rheumatoid arthritis? Why did you think that the patient had rheumatoid arthritis? Right. So that is important. Right. So about the investigations which are already done, can you tell the results of the investigation, or can you just say the patient has undergone this? Now here you have to be a bit cunning. Then you can tell the results. Then make an exam the exam pyrexia of unknown origin. And as you know, the common causes of that in an exam setting is infective enterocarditis. Then leda මේ මහත්තයා මේ ඊයේ මට එකක් කරා ඒකේ විස බීජයක් තියෙනවා කිව්වා පපුව ඇතුලේ මේ දැන් ඒකට බෙහෙත් දෙනවා මේ එහෙම කියලා. Now you can say that to the examiner, but මොඩයිනේ බං ඒක කියන්නේ නැහැ නේ උඹලා හොයාගත්තා වගේ. What you are going to hide that information and tell the patient undergoing echocardiogram, patient is not very clear about the results or something like that, right? ඊට පස්සේ උඹලා කිව්වා I think this is infective endocarditis කියලා you උඹලා නිකන් මහා bright කියලා වගේ you present that, right? So that is a skill. And also you will learn with experience that there are some things that you are little poddak uyala cook kalla ganna ona. For example, you can't always follow the patient and what they tell you, right? Poddak eka podda lunu ambul tikak dala haddala ganna one when you present a case, which is especially important at the exam. Boru kiyanne kiyane kene, but you know podda lunu ambul dala ganna. Hari? Right. Umaya is asked, can we include relevant components of family's drug history? So you can include relevant components of the family history or drug history into the presenting complaint if you think that it is important or relevant. You can, right? You can. In the history of the presenting complaint, you can talk. So for example, if a patient comes with renal failure and that's your problem, and the patient has a family history of polycystic kidney disease, you can mention that right at the start. Chronological, yes, Hashir. So the in the chronological order of presenting, should we include the investigation in order, or is it better to leave those at the end? I would prefer to leave that at the end. Okay, the investigations, you can just summarize that at the end. Otherwise, it disrupts your thought process or the process of the person who is listening. Remember, the person is listening also to make a diagnosis. Okay. Pura, I'm not very clear the question you're asking. Could you rephrase that? Okay, any other questions? Right. So this is important. Then reproduction පාඩම් කරන ගමන් මේවත් කොහේ හරි ලියලා තියාගන්න or make sure that these notes are safe, because I bet you are definitely going to need this for your final medicine exams. And දැන් උඹලා නිකන් අර එකපාරට නිකන් නිින්දෙන් අවදි වුණා වගේ නෙවෙයි, මේ ඒව වැඩි දුරක නෙවෙයි final එක. හරිද? So make sure time flies. So make sure you understand that you are no longer a Totta Baba medical student in your first or second year. You're almost finished now. Okay? Look. Follow up in history if they stay in hospital for a long time. Yes, okay. So that is a different thing, Purna. So if a patient is in hospital for a long time, then in your history, you can obviously summarize that hospital stay. And daily status is a different thing that you do, and that is more of a house officer job. So you learn more on how to do that practically when you go into the wards. Okay, that's a different thing altogether. Not really more for exams and case presentations. It is obviously a more house officer job, how to take a daily status and how to follow up patients in hospital. All right. Okay. Right. Okay. So that's fine. Sarangini,
Yes, sir.
tomorrow same time is okay?
Yes, I think should be okay, sir. Others, are you okay with it?
Right.
I think should be okay.
I think should be fine. Then, do you have or does anyone know how to set up a Google Classroom? Can you ask Sarangani? Because I have a Google Classroom for the 2013 people. It works very well because you can post stuff on that and all these presentations and
Okay.
it's more useful for question sessions. I'm doing some question sessions with them where they answer SCQs and things. So that it's more useful for that purpose. But it's easier to share educational material through that. It's not that difficult. They made one and send me the password for their batch.
Okay.
Just find out how you can do that, and then we can do that. And WhatsApp group
Yes, sir. Sir, it's I think okay. Sir. Shall I add you to it, sir?
Yeah. Okay.
Okay, sir.
Right. So then tomorrow we will do cardiovascular system examination and physical science. Okay. And we have tomorrow is Wednesday, Thursday, Friday, and one more session on Monday or so. All right. Then you have your exams, and then we'll restart after you start your clinicals. And then every week, generally on a weekend, I can, no problem. Or any other day that you like, where everybody sort of comes and then we discuss a case.
Okay.
And we can do that every week. So that will be about 16, 17 cases for the whole medicine appointments day. So that will be a good thing to do if we can do that.
Okay, sir. All right. Okay. Thank you, sir.
Okay. See you tomorrow.